Will do. Thank you so much.
Yeah.
We're just going to go ahead and start it so that you guys can get on to the ORs. So I'm Dr. Tam Daniels. I'm in charge of your PACU rotation, and I'm one of the APS attending. So Megan's going to get the wonderful pleasure of being tortured this week on pain rounds. So that's where you'll see me mostly. So you'll see us on pain rounds or as a block attending. So today we're going to go over the PACU. So important things to know, this is like the basics. If you read like Basics Anesthesia chapter on PACU, this will cover most of the things that, at least as a CA1, what you want to focus on when you're chatting with people and handing off cases. So defining what the goal of PACU is, what the standards are that ASA has lined out for PACU care, transition of care. It's going to be fun. Sorry, this is like timed with my narration way back in the day. Early post-operative physiological disorders, so the big things to be aware of when you drop patients off of PACU or you're covering the PACU, and then discharge criteria for patients to be approved to leave. So the PACU is designed and staffed to monitor and care for patients who are recovering from the immediate physiological effects of anesthesia and surgery. So this spans the transition from delivery of anesthesia in the operating room to a less acute monitoring environment. So the ASA has laid out 5 standards for any post-anesthesia care unit. So the first one is that any patient receiving general anesthesia, regional anesthesia, or monitored anesthesia care shall receive appropriate post-anesthesia management. So the patient has to be accompanied by a member of the anesthesia care team who is knowledgeable about the patient's condition. Upon arrival to the PACU, the patient should be reevaluated and a verbal report provided to the PACU nurse. And the patient's condition shall continually be evaluated in the PACU. And a physician is responsible for the discharge of the patient from the PACU. So different transitions of care, which you're already familiar with some, right? So preoperative care that you're getting from even the nursing if something changes in the pre-op area. Anything that's happening intra-op, you're aware of, right? Because you're the provider. And then assessment and report of their current status, right? So when you get to the PACU, the first thing the nurse wants to know, right, is your patient stable, right? Is there anything acutely that has to be managed? And then is there anything else they need to do, right? So do they need to send labs? Do they need to do other things? So when you're looking at the preoperative history, the big highlights that everyone wants to know are patients' allergies, systemic medical illness, so things like hypertension, diabetes, anything like that, chronic medications that the patients take, any pre-medications, right? So oftentimes we are ordering Tylenol, meloxicam, things like that, especially in joint patients. So nurses need to know of things that are already provided. Any pre-op pain assessment and plan for control, and then their NPO status. This is going to be interesting. Sorry, guys. I talk faster in the real world, and this is going to be time for. We're going to try this. All right. Okay. So intraoperative factors, things we care about. What surgical procedure did the patient have? What type of anesthetic did they receive? So was it a general, regional, just monitored anesthesia care? Type and difficulty of airway management, any relaxant that you provided and whether you reversed or not. Type and amount of opioids administered. I's and O's, so any IV fluids you gave. Was it a colloid? Was it crystalloid? Which one was it? How much did you give? If you're monitoring output, what do they have? Any estimated blood volume, blood loss. And then vital sign ranges. So this is kind of like when you're in a neuro case and they have goals for you intraoperatively. Okay, well, what did I keep them in between? Or did I have issues and they were labile all over the place? So it kind of gives them an idea of expectation. Any lab results you've had and any medications you administered. So people who need stress dose steroids, immunosuppressants, vasopressors, anything like that. So assessment of the current status, right? So when a patient comes out, sometimes they're pretty sleepy. So one of the primary things that we want to be paying attention to is, are they breathing, right? Or is their airway patent? And if they're ventilating appropriately. So somebody can be breathing, but if they're taking shallow breaths, we're probably not ventilating very well. Cardiovascular status, so heart rate, rhythm, blood pressure, their level of consciousness. So you'll see like on your post-op handoff note is ask kind of one of your check little boxes is like, oh, are they sleepy? Are they alert? Are they all those things, right? Because that's what we're kind of assessing. Level of pain management. So this is where we can discuss if you've been running epidurals, if they have peripheral nerve blocks, have you been running lidocaine, ketamine, anything like that. Their volume status. So again, if they're already vasopressors, are they appropriately resuscitated, or do you think more resuscitation is needed? Size and location of lines, so peripheral IVs, A lines, central venous catheters, and kind of your overall impression, right? So you can, as you go through residency, you'll kind of get this overall gestalt of how a patient's doing, right? And so like if you're like, well, I mean, they're doing fine now, but I'm concerned about X, Y, and Z, you can communicate those things. And that's very valuable, right, of having that insight, because you've been with the patient for the last so many hours compared to the nurse. So the most important packing instructions that they want to know about is kind of following everything you're already signing out. So airway and ventilatory status, what is acceptable vital sign ranges? So this is really important in cardiovascular patients and neuro patients. They will have strict parameters that the nurses need to follow. Any anticipated cardiovascular problems, if they have been going in and out of rhythms, things like that. Any diagnostic tests, so if you need to check a hemoglobin, if you need to check electrolytes in the recovery room. And any therapeutic interventions and goals prior to discharge. So there are certain urology patients that they're like, nope, the patient has to urinate and void before they go, right? So I know that sounds silly to us, but it's things that like we know, probably from being in that room, that we can help the nurse know and be aware of, because that's not a criteria for us to discharge, right? So that's special to what they had done for a procedure. And then who's the responsible anesthesiologist? So if there's anything going on, who needs to be the first person alerted, and who needs to be the one that makes the decision of whether it's okay for them to discharge home or not. So early physiological disorders in the PACU. So the ones I highlighted in yellow are the ones that we're going to kind of delve into a little bit more today. But the things that we encounter the most in the PACU, upper airway obstructions, probably one of the most common. Patients who are hypoxic, any hemodynamic instability, patients that have postoperative nausea and vomiting, patients with delirium, and then decreased body temperature. Other things to be aware of, as you can imagine, some of our patients are super sleepy, so delayed awakening in the PACU, pain issues, decreased urine output, or if the patient's having cardiovascular symptoms of hemorrhage. So upper airway obstructions, defined as the loss of pharyngeal muscle tone. So the patient actually has that paradoxical respiratory pattern. If you've ever seen this, it almost looks like you see them trying to take something in, and you see the muscles move, but nothing's actually, like you'll never see chest rise with it. I know you guys just talked about neuromuscular blockade yesterday, so residual neuromuscular blockade. And this can all kind of be masked, right, because the diaphragm comes back before the pharyngeal muscles. So even though they're trying again to inspire and they're pulling down that diaphragm, the muscles aren't in tone to stem to open the airway yet. Patients with sleep apnea, laryngospasm, and then airway edema. So with obstructive sleep apnea, this is obviously these patients are high risk to have airway obstruction for two kind of main reasons. Well, the main one being the redundant tissue, but again, having that muscle tone to hold open. So these patients typically need to be much more awake when you're pulling the breathing tube, and you need to make sure that they're actually able to follow commands and kind of be with it to keep themselves breathing. They're also they have increased sensitivity to opioids and benzodiazepines. So you can imagine if a patient gets narcotics and then already have benzos, we get an additive effect in these patients. So it's just something to be aware of in the back of your head that less is more sometimes. Let it actually have the time take effect. Don't throw the kitchen sink at these patients, especially with medicines that double up. Yes?
If they have already previously been diagnosed with OSA, do you just automatically throw a CPAP or BiPAP on them, like whatever they have at home?
No, we ask them. So every patient's asked to bring their mask. So a lot of them have like the nasal pillars, if you've ever seen those. So they're asked to bring whatever is fitted to them already. Some do, some don't. If they're really awake and taking good volumes, right? So you can, when you're about to extubate, right, you can see on your monitor how well they're ventilating, right? So you can see your tidal volumes, you can see the oxygenation status, all those things. So if they're doing that without additional support, right? If you're not on PSV Pro and it's supporting those breaths, you can assume that's what they're going to be able to take, right, when they're extubated. So not necessarily. Now, if somebody is having issues with oxygenation, right? So CPAP, it's going to fix oxygenation, right? If that's what you're doing. It's not going to fix ventilation, right? So if their CO2, if they're not ventilating enough and their CO2 builds up, you need BiPAP. The CPAP's not going to do it. So that's a kind of important thing to realize if your issue is oxygenation versus ventilation. So no, we don't automatically order it for them. If they have issues, then we call respiratory therapy and have them come and set it up for us.
Just logistically, in our PACU orders, there's that OSA 1 and
Yep.
2. Like, what do those mean? Like, don't think anybody's talked to us about that.
So when you go through the order set, so basically the idea was that a patient who's at high risk, so somebody who already has a diagnosis or is at risk for it, stays longer with us in the PACU to make sure that they're going to be okay before they go home. So there was studies in the past that have said patients who have OSA and are having issues oxygenation in the PACU have a higher risk of having, dying basically at home, because if they go home with narcotics, they take a narcotic and they don't wake up, right? They have an injury. So there was the older studies that said that, and now people are kind of getting away from it, but to be on the safe side, especially in outpatient procedures, that's kind of in place to just say, okay, well, we should, at a minimum, should watch them this long. If a patient's doing fine, they don't have to stay that long. So they can call us and say, hey, this patient's been sitting 95% on Remair for the last 2 hours. Do we need to wait the third hour? And if their pain's controlled and things like that, sometimes people will be like, no, it's fine, let them go.
And then for us, did we just hit the OSA 1 for like a cold as well? Like if it's undiagnosed OSA, or is it 2? I was never.
I have to look back at the order set.
Okay.
Yeah. This is the one thing I don't usually do the orders.
Okay.
Right, so they just call me about them. But yeah, so if somebody's at high risk, so the nurse always does the stop bang questionnaire. So as you can see, identifying patients at risk. So when a patient comes in the pre-op area, that questionnaire is done automatically for every patient. So you can actually go into their pre-op assessment and see what that score is if you wanted to. And you probably should be aware of what stop bang stands for as well. So something to look up if you guys don't know what it is. So it identifies people at risk who haven't necessarily been diagnosed, right? So if you ever hear the nurse, usually when you show up, the nurse is like, oh, have you ever heard them stop breathing, right? That's all part of this questionnaire that they're asking. So that's something that should always be on your radar. If you're concerned for it, take a look at their questionnaire. You don't have to repeat it, right? You can just take a look at what their score was. Usually you can walk in and get a feeling of a patient who's at risk, but there are some patients who, if you're ever an outpatient and somebody's having a surgery by some of the surgeons who do the palate surgeries and things like that, if they're thin and have a history of obstructive sleep apnea, that probably means they have a difficult airway, right? Because they have if they're otherwise normal anatomy, right, there's something that's causing issues. So they kind of tell you always have the back of your head. And then like you were talking about, considering CPAP for the PACU. So if you need to, it's okay to extubate. Some people do extubate to CPAP. It's a little bit tricky sometimes setting up in the OR to truly do that. But if it's safe enough, it's fine to go to PACU and you can call ahead and have RT there, like if you think you need it right when you come out, and they'll be there for you. So two other things that can occur, and oftentimes the laryngospasm occurs in the OR for you before you even get to us in the PACU. It's a complete occlusion of the laryngeal opening due to the spasm of the vocal cords. This usually occurs between extubation and complete emergence. And the way you would treat it, and I don't know if you guys have had this experience yet already, because it sometimes occurs very early in training. Jaw thrust with CPAP, you can always deepen the anesthetic, and if you have to, reapply muscle relaxation. Patients with airway edema, this is just tissue edema, or if they have hematoma, so you can think about people with like people who have had ENT surgeries or having the big neck dissections, it's going to occur. Patients at risk, so this is long procedures, right? Somebody who's been getting a lot of IV fluids, they've been under anesthesia for a long time. The type of surgery, so ENT, carotid, any C-spine surgeries, patient positioning, so if you can imagine somebody who's on their head basically the whole day, everything, you're gonna have fluid shifts that way. And then large estimated blood loss and having IV fluid resuscitation, right? So if you think about the crystalloid-colloid ratio of how to appropriately resuscitate somebody, if we're leaning on crystalloid, we're giving them a lot more volume than they necessarily need just to fill up the tank, right? So something to have in the back of your head, especially for these like really long neuro procedures, spines where patients are prone for a long time. When you're in there, sometimes we'll do leak tests, like make sure that they're not completely swollen around the endotracheal tube to make sure that it's safe to pull the tube. But if you see swelling here, you can imagine that you already have swelling also that you can't see internally. So this is where the scleral edema is one of your best indicators, or facial edema. And any patient that goes prone for a long time, I counsel them to expect to be swollen. And it's really good to tell family members that, because some of them get really swollen and it's just kind of a little bit unexpected to see if you haven't warned a family member. You sit them up, it goes away pretty quickly, but I think prepping people for those things, that it seems normal to them then when they see the patient in the PACU. So management of airway obstruction, we talked about this, non-invasive ways, jaw thrust, CPAP. You can put oral nasal airways in. Remember, an oral airway should never be in an awake patient, right? So if a patient has their reflexes, it can cause gag reflexes and then they could vomit from it, right? So if somebody's kind of in between that, kind of still emerging, nasal airways or nasal trumpets are phenomenal. If you put some lidocaine ointment on there, once it goes in, they fight you, but the lidocaine ointment will numb everything up. It can stay for quite some time. So don't ever underestimate the nasal trumpet. And then obviously the most important thing, identifying and treating the etiology. What's the reason why we're having issues? And if you have to, it's not uncommon, it's rare for us to have to do it, but there are a few times a year that we have to reintubate patients in the PACU for different reasons of either not being able to protect their airway or they're having pulmonary edema or things like that. So if you have to, you have to. And that's just the reality of it, right? But you are going to try a lot of other things before you get to that point. So hypoxemia, obviously there are multiple etiologies that you guys have all studied in the past. So pulmonary shunt, so this for us, right, we call it atelectasis. Patients who have alveolar hypoventilation, and then obviously the other causes, so ventilation perfusion mismatch, pulmonary edema, aspiration, PE, pneumothorax, congestive heart failure, and obesity. So these are all things to kind of have in the back of your mind, but you always hear the saying, like when you hear hoof beats, think horses, not zebras, right? So think what's going to be most common and treat those things versus kind of searching for like the needle in the haystack of, oh, this might be this. So a lot of it's a process of elimination. So atelectasis, I'm sure you hear this all the time. So as patients go from sitting to supine, right, they automatically get atelectasis. So closure of the smaller airways of the lung. They have reduced or absent gas exchange. It's affected by position, and when we give them anesthesia, we make it even worse, right? So we're kind of giving them a little bit of a double whammy. So this is when you see that you'll, as you go back and check out your patients in PACU, in between cases or on the floor, the nurses are using ascending spirometry primarily, right? Because they're really trying to force them to open up all those airways again, create that back pressure to pop those little airways open. All right, so alveolar hypoventilation, typically from depressed drive to breathe, either generalized weakness, so we discussed this residual neuromuscular blockade. Patients with neuromuscular disease, always good to have in the back of your mind. Anytime you have Parkinson's or people who already are weak, this can also contribute to this in the recovery room. And then restricted pulmonary conditions. So anybody who has chest wall deformity, post-abdominal binding or abdominal distension, that can all affect their ability to take good deep breaths. And then obviously residual effects of medications, right? So our narcotics are one of our biggest offenders for doing this. So these are all things to kind of always have in the back of your mind. And I kind of put a star here that all these things are exacerbated at higher altitude, right? So, if you talk about criteria of a patient going home and their oxygen saturation should be 92, 93%, there's a little wiggle room here, right? Because we already are not providing as much to them. So, again, you kind of have to remember where we are a little bit when you're dealing with some of these patients. All right, so management, this is supplemental oxygen, and then normalizing the PaCO2. So waking them up, right, stimulating them to make sure they're taking nice deep breaths. If they're over-sedated, is it possible that they need naloxone or they need flumazenil? So flumazenil is your reversal for a benzodiazepine, right? And then controlled ventilation. So do we actually need to maybe be going towards BiPAP, where we can make sure that we're not only oxygenating but ventilating the patient. And so it's really important to realize that your pulse oximeter doesn't tell you about ventilation, right? It's purely measuring oxygenation. So this is, again, where you can get in that trap of, oh, well, their oxygen stat looks great, but they're not waking up. And it's probably because they're retaining CO2. So there are a lot of moving parts, but if you kind of go through your head of like, okay, that's fine, what's the next thing it could be? And kind of go down your list in your head. So you have multiple options of oxygen delivery. So part of it's dependent on the degree of hypoxemia, right? Their surgical procedure and patient compliance. So you'll often hear the patients like, oh, I have OSA, but I hate that CPAP machine. So they absolutely refuse to use it. So, we have the non-rebreathers. We should have the simple masks now, and we have nasal cannula. That's all that's in our repertoire, right? If we need to do high flow nasal cannula or we need to do CPAP, BiPAP, we do have to get RT involved for those machines. So important things to know, and I think this will be changing recently. They're going to change the way you have your masks and setting up the FiO2 on it. It's supposed to be more straightforward. But right now, on a regular set of nasal cannula, you shouldn't be exceeding really 6 liters per minute. And then as you see, this is kind of how you calculate your estimated FiO2, is that each liter that you increase, your FiO2 goes up by 0.04. So it's just something to be aware of. If somebody has high flow nasal cannula, which again, this has to be set up by RT, they can actually get up to 40 liters per minute. It's kind of crazy. Like if you look at it, it's in the chart, you're like, this makes no sense, but it's the way they're creating that high FiO2 flow. The issue is they have to have proper humidification, as you can imagine, right? You're getting that much oxygen, it's really dry. So that's why it's set up by them. And then anytime you take the face mask or at least the non-rebreather, it needs to be on a minimum of 8 liters per minute. So at least 8 or 10 when you're sitting. Otherwise, they're not getting enough flow. They're going to start rebreathing kind of what's in there. And that's part of the rebreather, but that's the flow you need. And then obviously the non-invasive positive pressure ventilation. Important things to know about this. So people who have nasal surgeries or have some kind of skull thing, anything like that, it's important to ask the surgeon if there's a reason they can't have positive pressure ventilation. So even if you think about people who have esophagectomies, right, they can't have positive pressure ventilation. Surgeons don't want that. So if you're concerned about oxygenation, you need to have a couple things in place of, okay, well, if this happens, what am I going to do? Or the patient ends up getting reintubated. And that's sometimes what it is, because you can't put a CPAP or BiPAP on them. So it's good to know your limitations and realize that your toolbox isn't necessarily as full for that patient. So going towards non-invasive positive pressure ventilation, this does reduce the incidence of reintubation. And like I just discussed, patient surgical factors are a big part of this, and contraindications to this. So patients who are hemodynamically unstable, anybody with life-threatening arrhythmias, altered mental status, high risk of aspiration, right? Because what are we doing? We're delivering positive pressure, so we're not only blowing up the airway, we're probably already also blowing up the stomach, right? And then inability to use, like I just said, nasal or face mask, things like that. And if they have refractory hypoxemia. So if it's not working, move on to the next step, right? Like we don't just leave a CPAP on if it's not working for them. So patients have hemodynamic instability oftentimes in the PACU. So patients who have underlying hypertension, oftentimes if they're not controlled, are very labile, right? You probably already seen this in the OR where you're like, I can't make my record pretty. The patient's all over the map. Doesn't matter what you do. That happens to the PACU, right? It's the exact same thing. So patients who have hypertension have bigger swings. But in addition to that, you have to think about something else going on, right? So one of the biggest reasons patients have hypertension in the PACU is that they're in pain, right? It makes sense. They have a stress response and they're in pain. They're tachycardic and hypertensive. Patients who are hypercapnic, patients with advanced age, patients with smoking history, pre-existing renal disease, and patients shivering, right? As you can imagine, they're contracting their muscles, that blood pressure is squeezing like crazy, and you can't get a good accurate reading. Patients with hypotension, the biggest reasons, right? We under-resuscitate, they're hypovolemic. They're either having cardiogenic issues, right? So that means their heart's not functioning as well, or they're having distributive issues. So in the sense of like setting of sepsis, right? Everything's vasodilated and the tank's just bigger than what it was. So again, all things to keep in the back of your head. Hypovolemia, we talk about this third spacing and people say it's true, people say it's not true, right? We know that the tissue, like giving fluid, it leaks through the blood vessels into the interstitial space. Inadequate resuscitation, right? We oftentimes run patients really dry because we're trying to not overwhelm them, and then we get in the PACU and then they're still hypotensive, and then we're end up giving a lot of volume. Loss of sympathetic tone, and then obviously if the patient has a lot of bleeding in the operating room. And having hemorrhage. So cardiogenic issues, patients who might have myocardial ischemia or infarction while they're in the procedure room. Really important to realize that only 8 to 20% of these people present with typical chest pain. And it's sometimes can be difficult unless they have those standard tombstones, right? ST elevation, it can kind of be hard to tell, especially if your leads aren't in the right place, right? So think about it. We put our EKG leads on, and who is on, right? There's like this whole joke that like we finally keep the EKG leads out of the surgical field. But if they're not in the right spot, it's really hard to assess ischemia. So if you see things, it's fine to be vigilant. If things change in the operating room, or if you get the tombstones, I mean, that's the point you need to be discussing with the surgeon, saying, hey, something's going on, this isn't right. We have gotten 12 lead EKGs in the operating room before to determine if a patient needs to go somewhere else versus just being woken up. Patients with cardiomyopathies, right? So you might have a young patient that has a viral cardiomyopathy that you're unaware of, and their EF's actually half of what you think it will be. And then obviously patients can develop dysrhythmias, sometimes just underlying, or sometimes we give them medications that help them along their way. So you have your tachyarrhythmias, you have your atrial dysrhythmias. And so all these things to think about, right, is like, well, is there anything I'm doing, or is there anything that we're not taking care of that might be contributing? So are they hypoxic? Are they hypercarbic? Electrolyte abnormalities, right? So that can, I mean, you can see your T waves with potassium. You can see all the kinds of different changes. Again, pain, any temperature disturbances, right? So patients are cold. That can also cause arrhythmias, right? Acidosis and hypertension. So again, like I said, the majority of things that impact you, a lot of it's ruling out the bad stuff, right? And then you kind of go down and try to figure out what's going on. And then distributive. So this is going to be your typical, your septic patient, right? Affected kidney stone that just gets this release of things into their bloodstream, or perforated bowels, things like that. So you're going to have functionally a decreased afterload, right? So everything's vasodilated, your tank's bigger. We also contributed this with our regional anesthesia techniques, right? So neuraxial, we're really good at causing a sympathectomy with our higher epidurals. So again, sometimes it's their etiology, sometimes it's things we're doing. So as long as you know what it's from, you can treat it, right? So if you know you've got an epidural, and you'll see some of the tendings will bolus like 10 cc's up front, right? And then your pressure drops, and you're like, oh, my tendings suck, right? Like they totally set me up for failure. As long as you know what it's from, that's the important part, right? You're like, well, I'm intentionally doing this because I want good pain control, and I know how to counteract it. So I know how to give phenylephrine to counteract what I'm doing, right? So important to know that kind of cutoff for your exams is that T4, right? So if you're getting spread above T4, right, your cardiac accelerators are T1 to T4. So for your exams, that can come up sometimes about like where that's going to affect you. And then obviously understanding that when you critically ill patients, they don't have that reserve of sympathetic response that like a young person would be. You know, you see young people come in and they can tack away for a long time and it's fine. An older person or somebody who's been really sick in the ICU for a long time doesn't have that reserve. So to be aware that sometimes you have to support them a lot more than other people. All right, so the one that you get tested on all the time, your favorite post-op nausea and vomiting. So the risk factors are important to know, and you'll see, right, when you do your pre-op note, it says like what's your risk, what's your score, all those things. You will get tested on these. They pop up on a lot of things. So risk factors being female, non-smoking, as a child, or a history of PONV. The other risk with it, your anesthetic, right? So as a patient getting a volatile anesthetic, getting nitrous oxide, large doses of neostigmine or opioids can do that. And then surgery. So your type of surgery is actually pretty important. So eye muscle surgeries, inner ear, and even laparoscopic surgeries are considered to be higher risk for it causing PONV. So you can imagine when you're on peds, all these things add up, right? And kids like to puke after anesthesia, and that's just so there's a lot of things you can do to prevent it, but then you also have to think about the medications to prevent and additive things. We like to throw a lot of medications in our patients regarding this because this is one of those quality factors of how well our patients are doing after anesthesia, right? So oftentimes you guys are giving dexamethasone in the OR, right? The patient's getting Zofran before they wake up. If they have issues with motion sickness, or sometimes the scopolamine works really well, right? So they'll get scopolamine patches. You can do diphenhydramine, metoclopramide, and then propofol, right? So sometimes if you're, as a PACU resident, you'll see if they're really nothing is working, we will actually go to just tiny doses of propofol to see if we can break it. And these are kind of, you can see the treatments. Some of these can be both preventive and some can be only preventative, right? So we don't ever use dexamethasone for trying to rescue PONV. So something to think about, like the mechanism of how they work, of whether they can be used for both or only for prevention. All right, so delirium, 10% of patients over the 50 years of age mark can have delirium within 5 days post-operatively. As you can imagine, this is super expensive for the hospital, right? Because oftentimes they have to stay longer, they need different medications to help counteract it, and there is an associated increased morbidity and mortality with these patients. So the risk factors to kind of have in the back of your mind, so advanced age, anyone that already has some cognitive impairment, if they have decreased functional status, patients who either have a history of alcohol abuse or currently abuse alcohol, and if they've had a history of delirium in the past. So those are all things that can just raise a flag for you to do other things to help prevent this down the road. And then intraoperative risk factors. So if they had a lot of surgical blood loss, their hematocrit less than 30, or if they had a lot of transfusions. And like I said, a lot of these things get confusing. So you have to rule out the other things, right? Rule out that they're not hypoxic and hypercapnic and they're having pain. and things like that before you kind of go down this route sometimes. And then patients, another common thing is shivering, right? So this happens more common than we realize. With general anesthesia, 5 to 65% of the time is kind of the supposed incidence of this. Less common with epidural anesthesia. The common thoughts are etiology, hypothermia. Normothermia, they kind of say that it's just that the recovery is fast, and so they kind of just get this like clonic activity. And obviously the big negative factor is that if a patient's shaking or they're having increased oxygen consumption, they're then having increased myocardial demand. So then we can have issues with ischemia and things like that on patients who are at rest support. If they're hypothermic, treating it, right? So put the barrier hugger on, do all those things in the PACU. And then obviously in a normothermic patient, people will use meperidine to help treat that. So the patient kind of like doesn't get big muscle aches also from it. Important to know, patients who are in OB, so when you do OB in the C-sections, they will always shake and they will always shiver, and that's more hormones. That's not and everyone's like, oh, did your anesthesia do this to them? And it's just something to have in the back of your head, like just to reassure them, because the patients start getting all nervous and fainters. Mm-hmm.
Okay.
I mean, even epidurals can do it too, but usually it's the patient in the C-section room.
It's not with like the guide procedures, it's just the deliveries.
Yeah, because it's just their hormones, right, are such higher levels. So usually, the hormones cause a lot of, as you can imagine, physiologic changes in pregnancy, so something to be aware of.
Meperidine, so that you can't use it in a hypothermic patient?
You don't typically, I mean, you can, but
So
typically you want to correct what's already going on, right? So if they're shivering because they're hypothermic, you want to correct that.
So this is more symptom management, I guess, rather than,
Yeah. The meperidine is really because it's bothering a patient, or like they're shaking so much you can't get a blood pressure on them, or there's some patients who've gotten it and don't like it. So you'll have patients who have an allergy to meperidine.
Do you know like the dose just in case?
It's in your order set. Yeah. So always start lower with older patients, and there's usually sometimes there's an age cutoff for doing this. So this is mild to moderate hypothermia. As you know, it affects your coagulation. It prolongs neuromuscular blockade, may delay awakening. So there's a ways to treat it. Forced air warmers, fluid warmers. And then the important thing to be aware of, discharge criteria, right? So these are the 5 categories that nurses rank each patient on, and they get a score from 0 to 2. So activity, breathing, circulation, consciousness, and oxygen saturation. So as you see, they don't have to eat to go home, right? They don't have to urinate to go home. And these are things we always think that they need, but these are the things we care about. So like I said, if there's a surgical indication they have to stay for a reason, being able to tell the nurses that is really valuable for them so that they know that's what they have to do. We, at the end of the day, have the final say of if it's fine for a patient to go. Here, the nurses, if they meet a certain score, the nurses can let the patient go to the floor. To go home, if they're not meeting this criteria, they have to call us. And we have to, if we can't come see the patient, which we try to go see the patient, we can verbally give them like an okay, it's fine to go, or hey, can you hold off? I need to come see the patient. So I know this is a lot of information. It's like drinking water from a fire hose these 2 weeks. You guys will do PACU rotation of CA2s. So we kind of shifted it back so that I think you'll have more exposure to other cases. So by the time you get to the PACU, you can kind of, it's really a self-directed learning rotation, right? So you're like, oh, I don't know that, I need to focus on that. So I think it'll be more valuable for you versus like, you're there and you're like, I haven't even done a spine. I don't even know, I don't even know the big things to watch for. So hopefully the shift will be more valuable for you. But if you guys have questions, seeing your patients on the floor if you can, like even the next day, I think it's valuable learning. Yes, your attending is going to know how your patients do, but it's your job, right, to also follow up on that stuff. So I think it's, as much as sometimes people feel like it's, oh, I'm so tired, right? Even if you can see the next day on a break, I think it's valuable to see how your patients do and get that feedback. Or when you're co-residents or the PACU resident, they can be like, man, come on, you have to control the pain better, right? But that's valuable. And it's a less judging environment, right? If your colleague's like, dude, that was great, or do that. All right. Questions at all? I know you guys have to get to the OR.
Thank you so much for your lecture.
Yeah, no problem. And then the PBLDs, if you guys want to just look at them online, I don't usually pull it up here because it's just really a chatting thing. So if you have time, just pull them up on campus, glance through them today, and then we can talk through them. Does that sound okay?
Yeah, sounds good. Are you the pain attending next week too?
I am not.
You know who is?
I can look at it. I can tell you this afternoon.
Oh, cool.
I think it's Marina, but
I start at pain on Monday.
oh yeah. Yeah, I mean, if you have, you're in the OR today?
No, I'm actually in pre-op clinic.
Oh, with Angie?
Dr.
Dr. Stelter together. Dr. Stelter, you can always ask if you want to come, like, just get a brief overview, because it is kind of overwhelming the first day.
Oh, no. Dr. Olivia Romano, excuse me, she told me to come tag along with her.
Yeah, that's what I'm saying. So just ask Dr. Stelter if you guys, like, in between something, you're welcome to join us partially.
I
I don't know how
have
many
five.
patients we have.
I have like 5 patients.